So, good evening, everyone. Thank you so much for joining us today. And apologies that we have to do this here. I want to believe this will also give all the people that missed the last session and those that wouldn't prefer to come on Zoom, they'll be able to watch this even if they are not live now. So, thank you very much for joining us. As you know, this is like maybe our last session for the month of March. That is in commemoration of 2022 International Women's Day. This is the second health talk that we'll be doing. We've done the one for infertility on Sunday. We'll try as much as possible to make the recordings available on our YouTube channel. So menopause has been selected as a topic because I want to believe I'm not the only one that know that it's one of the silent topics that we hardly talk about. Just like menstruation, it sounds like a sacred word that many people don't discuss, but as much as we run away from it, we can't, biologically, we as women, we can't run away from it forever. So, which is why we need to talk about it. We need to know what it is all about. It's not just about our period stopping. And that is the reason we have here with us today, Dr. Aminat Ajimotokon. She'll be taking us through what we need to do to know as women about menopause. I'll leave Dr. Aminat to introduce herself, and then she has the floor to take us through menopause. I don't know if she will be comfortable to be speaking alone if I switch off my camera, or if she would prefer that I still put it on. So she won't be the only one here.
Anyone is fine. Don't worry.
Okay,
I'm
that's
also
fine.
to see your face. That's
Thank
fine.
you. Thank you, Ma.
Okay, thank you very much. As you said, my name is Amina Ajimotukon. I'll just be giving us some, all right, rather, giving some little bits about menopause. Amina did say well that it's a topic that we're not very vast with. We just know, okay, menstruation, menarche, you see your menstruation, and we keep, having the menstruation. But during the cessation, what are the things you should expect to see? What should you do? Because it might actually be very stressing for some people. I don't know the audience we're talking about now, but some of us might even be having it before old age. And so I'll be giving you some terminologies where we'll find, the menstruation season even before that usual old age. So I'll try my best to give as best as I can. I'll try not to bother you with so many terminologies. And when we get to the bit where I feel that you need a doctor, then I'll tell you to seek doctors. Because if I keep telling you the medications and all that, it might not really do much.
Thank you so much.
Peradventure, I'm going very fast. Please feel free to, call me back, and then any question, I'm happy to take it. All right. So the objective of this menopause is for us to have an understanding of the symptoms. Sister Amina, would you want to share the slides? So the objective basically is just, a better understanding of the symptoms of menopause, understanding the impact of menopause on the quality of our lives, and understanding the management options that we have. We have. So this discussion will be going through the definition. I'll give you some terminologies, give some causes, the prevalence of menopause, symptoms we should look out for, the investigations that we do when necessary, the complications that we can get, and the management options we've had. Then would you just take that along? So as a simple definition, what is menopause? Just as, life started and we've got menarche, which is the time in which we first see our period. Then there's a stage that the period is going to cease. So now, when is that stage? When the period ceases, that's what we call menopause. So menopause is actually a biological state in a woman's life when menstruation stops permanently due to loss of ovarian follicular activities. That's what menopause is. So it occurs with the final menstrual period and is usually diagnosed clinically after 12 months of amenorrhea. Amenorrhea simply means no menstruation. Generally, the mean age is 51. In Nigeria, it's just within that range. There's actually a range, so it's not everyone you find to have 51, but the mean wage is 51. So we look at it from anything from 50 to 55, depending on the personality and many other factors that come in play. So other terminologies we'll be talking about is perimenopause. This is also called menopausal transition. When menopause is trying to come in, you start seeing some signs, and one of which is your menstrual period, which used to be regular, would no longer be regular. Your interval, your flow, it can be either too much or it becomes very scanty. So so these are the perimenopausal period we're talking about. So it's the period before the menopause when the endocrinology, biological, and clinical features of approaching menopause starts to come in. And what do you find here is characterized by irregular cycles of ovulation and menstruation, and ends 12 months after the last menstrual period. So when we are talking about the perimenopause, you start seeing some other signs of menopause, the hot flushes, which I'll be telling you the signs of menopause anyway. You see them, but it might not be that constant. You start feeling some, apart from the menstruation becoming very zigzag, very hazard. You see some feelings in yourself that you'll be knowing that, no, this thing is knocking. And that's why when we have people that have it before that age, they need to also know that identify that there are menopausal symptoms, and it could be caused by premature ovarian failure. So postmenopause is the time after a woman has not had a menstrual period for 12 consecutive months. And what this means is that before we can actually diagnose someone to say, okay, this is menopause, the person would have missed the period for a whole 12 months. So there will be cessation of the periods for 12 months. So if peradventure you see someone, or your mom or your sister misses period for 3, 4, 5, 6 months, and the period does come back, that's not menopause. So we could term that to be perimenopause. But as long as it becomes more than 12 months, then it's menopause. And it has to be consecutive. So we have a situation, or some situation, where we have early menopause. And this is when we're talking about the cessation of the ovarian function occurring between the ages of 40 and 50. And that's why it's important that we talk about this topic, menopause, because it doesn't mean that because we are still young, we might not get the symptoms. We can actually get them. So there's a terminology for that. And if you find that, because the menopausal symptoms itself can be very distressing, it can actually affect your quality of life. So it's better you seek medical attention, and that's why we're talking about it. So in this case of early menopause, I did tell you that the age range is 50 to 55 with a mean of 51. But when you find out that you're seeing these symptoms before that age, especially between the ages of 40 and 45, in the absence of other causes of secondary amenorrhea, I know we did infertility, so we must have been used to hearing the word amenorrhea. So in early menopause, when you find it and there's no other cause, and that's why I said the first thing is you're going to seek medical attention for them to help you rule out other things that could have been happening. So they must be able to rule out every other thing that can cause you from not seeing your period before they say no, then you're having the early menopause. So also we have what we call premature menopause. And this describes the definitive loss of ovarian function before the age of 40. So you see what we're talking about. Before the age of 40, that's a premature menopause. And that's when, for her ages, if you start seeing these symptoms, you should start thinking that I hope it's not as if I'm going to menopause. For example, for those people that have had, when they say bilateral oophorectomies, that they've had their ovaries out. Every month the mechanism of action of menstruation has to do with our ovarian functions. How it develops, then it breaks the egg and becomes blood, and we let it out. So when the ovaries, which is the main thing that brings out our periods, when it's out, that mean of bilateral oophorectomy, they cut them out. Definitely, you're pushing that person to premature menopause, because the things that should be done by the ovaries, the ovarian function, will be lost automatically. So that's one of the causes of premature menopause, but that's not the only causes, or only cause rather. So some situation we can also have is premature ovarian insufficiency, which they call premature, which is also a premature ovarian failure. So in this case, that's the oophorectomy. That's when we take off the both ovaries. Is a surgical cause, and this is a clinical cause. So there's a clinical syndrome that is defined as the transient or permanent loss of the ovarian function before the ages of 40. So before you're at the age of 40, you find out that the function of the ovary is not doing well. So because of that, you start having these menopausal symptoms. And what we have in this case is that it's usually characterized by menstrual disturbances. Either the person will start having amenorrhea, or the person will be having oligomenorrhea. Amenorrhea means that the person is not going to have menstruation anymore. And oligomenorrhea means that the menses become very scanty. Maybe sees a period this month. Normally, person gets to see the period every month. Maybe he has gotten a 28-day menstrual cycle. But when they start saying now that I don't even get to menstruate maybe once in 3 months, what's happening? Then it's becoming very scanty. That's oligomenorrhea. And that's one the first pointer to premature ovarian failure. There are also many other causes of oligomenorrhea or amenorrhea, but we're talking about the premature ovarian failure or premature ovarian insufficiency. And another thing is that you find potential spontaneous resumption of ovulation, menstruation, and spontaneous pregnancy. So there's going to be disturbance in all this pathway. Definitely, we know that if you're ovulating from an infertility presentation, you would have heard that if you're ovulating well, then you should get pregnant. As we doctors usually say that the best test for ovulation is pregnancy. And that's when we have clients or customers, or patients that come in and say, I've not been pregnant, I'm ovulating. I ask them, the question we usually ask is, how do you know you're ovulating? Some will say, because my vaginal discharge does somehow, I feel hot. No, that's not it. The best test for ovulation is pregnancy. So when you start having disturbances in all these stuffs, then you should start thinking that I hope it's not as if I'm going to premature ovarian failure. So what are the causes? Just as we know menarche, which is the onset of menstruation, pregnancy, menopause, these are just the natural stage in a woman's life. So it is not a disease. It is something that is like, there's nothing that starts that doesn't have an end. This is the end of menstruation. So menopause is just a natural stage in a woman's life. Unlike in men, when the sperm production continues into old age, women have a definite egg or oocytes at birth. There's a percentage that we have, and for every menstruation we shed it. So the number of it gets shed, so it declines with each menstruation. And the menopause is characterized by the eventual depletion of that egg store, and then menstruation will cease. So where our male counterparts can get pregnant, or can impregnate someone up to 70 years of age, for a female, we get to a stage that we cannot get pregnant anymore, and that's why they usually advise us to make AOY the sunshine. The number of eggs we have at birth get depleted over time. So if you do not make hay when the sun shines, in quotes, you might just realize that when you think you want to start making the hay, the sun has finished shining, the eggs are depleted, then you can't get pregnant. So, and another thing you should know that now, what are we talking about? During the perimenopausal period, the mechanism of action is what I'm trying to say now, as in the pathophysiology in the time. So what we have now is during that perimenopausal stage, that's the stage in which you start having the symptoms. It's not yet regular, but it's coming in. What does happen is that the ovarian follicular activities will begin to decline. The main thing that is responsible for ovulation is estrogen. So during this period, and inhibin too has its own role. So these are the hormones that are working in together, to get things done in our system as a female. So the major hormones that we'll be talking about now is the estrogen, FSH, which is the follicular stimulating hormone, and LH. So this is how the menstruation itself is a cycle. The first part of the period, you get your period. When you get the period, some hormones comes into action. When they come into action, then the follicle starts developing towards the end of the month or of the cycle. The follicles get matured, then it ruptures and it comes out with the menstrual blood. It comes out as the menstrual blood. So that's the cycle. So when you get into the menopausal period, then this estrogen and inhibin level would decrease. When that decreases, it gives the brain a negative feedback to the pituitary, causing the FSH and the LH to rise. So when this level fluctuate markedly from the pre to the postmenopausal values on an almost daily basis during the transition to menopause. So as the estrogen and inhibins are depleting, it gives us feedback, and they feel that no, they need more FSH, so it gets increased, and it happens daily at that period. So decreasing estrogen level will now begin to disrupt the menstrual cycle, and it would eventually cause other menopausal symptoms, which will be saying like the vasomotor symptoms, where they have the hot flushes, the night sweat. These are the major symptoms we've got in menopause. So what would this happen? You now start finding that there will be increase in the core temperature that would trigger an excessive thermoregulatory reaction, and it will promote the heat dissipation by peripheral vasodilatation and sweating. The main gist of that is just that when the estrogen and inhibins are acting, you start having these symptoms: hot flushes, increased temperature. That's what is triggering. And everything, you see them, they'll say they're having peppery sensation, they can't sleep well at night, different symptoms that comes on. And what this does is that the menstrual cycle tends to become anovulatory. What anovulatory simply means is that it's not everyone who menstruates ovulates, as I've said. So when you start menstruating and you're not ovulatory, eventually what happens? The follicular development would stop. So at the end of everything, at the end of the menstrual cycle stopping, what we usually have is that the menopausal pattern of low estrogen is what is going to be there, and we have a persistently high follicle stimulating hormone, which is the FSH and LH, is what will be in the system. And that's why if you take a blood sample and you want to check the hormone of a woman in their 50s who have attained menopause, you'll find out that the estrogen level is low and the FSH and the LH is going to be high. Okay, so what the risk of premature or early menopause may be increased if a woman has got these histories. What is the history? We're talking about early menarche. Early menarche means that, as I said, menarche is your first menstruation. If you have it early, now, to be honest, the age really, really varies depending on ethnicity, your location, your weight, and all that. But typically, the generation we have now, they have their first menstruation at 9, 10, 10, 11, depending. During our time, I'm sure, I think mine had 13. So it used to be later. I don't know what's happening now, but this is what is happening in reality. So those have increased as the earlier, it's like early starts, early finishing. That's what it just simply tells us. So if you have people who have had it earlier, 8 years, people having starting menstruation, 9, they might be at increased risk of having early menopause. Nulliparity means, or low parity. Nulliparity means that they haven't had a child before. They may have been pregnant, but they've not been able to have a live birth. Smoking is a very, 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 very high risk. It's an high risk in most of all the disease that we've got. Smoking is a culprit, and a personality that is very underweight. So all this makes someone to have increased risk in quote of premature or early menopause. So when we talk about the premature ovarian failure, which is premature ovarian insufficiency, this is also, so as I said, the age range is happening before the age of 40. So the normal ovarian function is going to be lost before the age of 40. And the main things that are identifiable in this premature ovarian failure, premature ovarian insufficiency is genetic, autoimmune, and idiopathic. Though we have others, unknown causes, at times you can't explain what's happening. At times infection, typically in our environment, tuberculosis and TB. So when we talk about genetic, what are we talking about? Someone who has got a strong maternal family history. All these biochemical problems, galactosemia, chromosomal abnormality, X chromosome defect. The problem just has to be from the mother. For, of course, our fathers they don't menstruate. It's definitely we mothers. So if your mother did have premature ovarian failure, the risk that you may get it is very high. That's what it means. When we talk about the autoimmune, it's just telling us that we've got some disease that are autoimmune, like that of diabetes, Addison disease, thyroid disease. All these diseases actually would give you an increased risk of having, premature ovarian failure. Iatrogenic menopause. For example, you talk about the surgery. They take away your ovaries early. Of course, they'll tilt you to menopause in good time. And now we're talking about treatments like chemotherapy for maybe some form of cancers, radiotherapy, when you have some hormonal treatments, maybe for breast cancer. And that's why you see them really, when they have such treatment, they go through a lot because the ovarian function is destabilized and in the long run might tilt them to menopause. So this menopause we're talking about, how common it is. It is very common, even if it is less recognized, especially back home. And the reason for that is we don't see, menopause is not a disease really, but it can actually affect some people's quality of life significantly. And that's why there's no point, being alive in your 50s and you can't still enjoy life. And that's why it's something that we should identify and, manage well. And that's why it's extremely common, but is actually very under-recognized and under-treated. Some people see it as weakness when they go for treatment for menopausal symptoms. No, your own symptoms might be different from mine. Yours might not affect you as much as it affects me. Imagine me having to go to work in my 50s and I don't get to sleep every night. And at work, I start nagging, to people and all that. Don't you think you need to be treated so that people not label you what it is not? Back home, I can imagine that, as they say, a woman's ethnicity, the cultural, the religious, the sociological, and generational factors may modify the intensity and the incidence of menopause. Back home, when some women even have some menopausal symptoms, they will be calling them yaji, which is, they don't understand what the person is going through. And the fact that the person doesn't really understand akomakorani unnecessarily. So, but understanding that it is menopausal symptoms, if you need help, please seek help, is very important. So what symptoms are we looking out for? That's the question. Vasomotor symptoms. These are the hot flushes, the hotness. You start feeling all sorts. Urogenital symptoms, which includes vaginal irritation, burning sensation, itching, dryness, reduced libido, urinary frequency, terminologies. Dyspareunia, you find, painful sex, you loss of interest in having sex, compared to how when your ovaries were functioning well. Then at times some people get recurrent urinary tract infection. They just keep treating and treating and they won't be getting better. Cognitive impairment is also very, very common, and mood disturbance, as I've said. So that's why we start timing them all sorts of names. Cognitive impairment, some will start having difficulty to remember things. It can be very bad that even they'll drop some things and they cannot remember where they dropped it. All sorts can come up. It does affect some people so much in their family life. So it actually alters their sexual function and they won't be able to perform really very well in bed. In which, taking some medication can actually improve that. And that's why for our generation, I think it's something we should look out on. Age is not a barrier to enjoying life and enjoying sex. So I know our parents' generation, what and then would not also want our spouse, our father, to marry another wife. In which, as I've said earlier, they are still active even up until death. And you on the other end, because of these menopausal symptoms, you're not enjoying, you feel you have gotten to the stage that you should. So what should happen to your husband? But if you take to the treatment well, you keep enjoying life up until the two of you want to go to grave. So, and the reason for all this thing is that you can imagine the vaginal dryness is very dry. So you're going to be having painful sexual intercourse. Loss of sexual desire and the libido, the drive itself is going to be lost. And the reason for that is that the estrogen, which helps it well, has also been declined. Your mood will be erratic. Your confidence itself is going to be troublesome. You won't be as confident as you used to be. Negative self-belief for some of us, where we come from, all these things will start attaching it, to something else. And even your altered self-image. That's why as we grow older, to get to a stage that you see that the breasts will start shrinking, the buttocks will start shrinking, all these things are all signs of menopause. Sleep deprivation is a very, very worrying problem for menopausal women. And that's why at times, if just because of your sleep, because that itself can affect your quality of life, you're not sleeping well. You can't be productive. Joints, muscle pain, headaches, fatigues, these are just things. But as I've said, menopause is not the first diagnosis. I can make a diagnosis of menopause depending on the age and the presentation of the personality above 50. But I would see a young lady in her 40s or early, maybe 38, 39, coming in with all these symptoms, or some of these symptoms, and the first thing I'll be thinking about is menopause. No. So what I would do as a doctor first is think of other causes. It's like a diagnosis of exclusion. You would have thought about other causes of these symptoms she's coming with. It might be UTI. What if she's having urinary tract infection? Why not, do the test to rule them out? Then when you are able to rule out all the common causes, then I can start thinking about premature ovarian failure in that age. So, but for a woman in her 50s that have come with some of these presentations or some of these symptoms, I don't need a test to make a diagnosis. So the thing is, as doctors, we do not routinely use blood tests. Maybe we're checking for the FSH or we're checking for the, to make a diagnosis. In someone perimenopausal, around the time of menopause, giving you, symptoms of menopause. You don't need anyone to tell you that, no, this is menopause, or you don't need any test to confirm. Especially if the person is not using hormonal contraception. Anybody above the age of 45 years coming with these symptoms, think about menopause. 45 to 55, think about menopause. So the only time you get to make it, you want to think about doing a test is one. Sorry, Okay, that's on the next slide. So menopause, you don't need that. Somebody comes in, tells you they've not seen their menstruation for 12 months. What are you looking for? What are you waiting for? Don't waste money. Go ahead and sorry, please. Go ahead and make your diagnosis. So, but some situations, as I've told you, we have to consider doing tests. For example, for those above 45 years, but they have not given you the typical symptoms of menopause, other symptoms are even more. So then you think to do some tests to rule out others, as I've said. If you see somebody between the age of 40 and 45 with menopausal symptoms, including a change in their menstrual cycle, then you can think about doing this blood test. And what do? They do the serum and the follicle stimulating hormone. You measure it to make a diagnosis of probably the person is early menopause or premature ovarian failure. Or younger than 40 with suspected diagnosis, you have to use a test to confirm that. I did say that earlier. Over 50 years of age, and the person is on contraception. For some of our patients, you realize that maybe they've had their, especially the intrauterine devices, the copper T, the IUD, they've had it for some years, and they are unable to actually. So the period itself has been very erratic following the insertion of those hormonal contraception. So it might be difficult for you to make a diagnosis of menopause on them. So on such people, you might need to measure the hormones, which is one of which the important hormone we measure for menopause is follicle stimulating hormone. As doctors also, I don't need to do a pelvic examination telling you to lie down to make a diagnosis of menopause. No. History will just give it out if you're in that age. The only thing that you might need is, okay, if there are other things that you're not very sure, probably the person is having, for example, coming in with some symptoms of menopause and says, okay, my tummy is getting bigger, I'm feeling pain. You could just do some, let me examine your tummy to see if there's anything, maybe it's fibroid or something, because many other things can give you some symptoms that might be similar to menopause. So what complications do we have most times? Postmenopausal women, they are at increased risk of osteoporosis and fracture. You see them with weakened bones, multiple falls, they'll be breaking limbs, breaking hands. They'll just fall, eat something. You see that they said they have, they fractured their hands. They're at increased risk of cardiovascular diseases, increased risk of stroke, genitourinary syndromes of menopause. And the reason for this is the fact that the estrogen depletion is actually ongoing. So for those premature or those that have had early menopause, that they are at increased risk of most things too, just as when they have the menopause. And for their case, we have more type 2 diabetes, depression, and also osteoporosis and the fracture. The thing about it is that estrogen is a very, 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 very important hormone in the system. It does a lot of functions. Female hormone, estrogen, progesterone. So in this case now, the estrogen depletion is affecting a lot of things. And that's why even for some people, we give them, they give them estrogen artificially when they've lost the 2 ovaries. We do everything to ensure that even if you have to do a surgery, you have to take away your uterus. We do everything to ensure that your ovaries are intact. You might not need a uterus, but not having an ovary can really make your life quite miserable. So what are the prognoses we've got for menopause? The ideal thing is, the duration, the severity is just when you're just coming into menopause, you'll be feeling all these bad symptoms. With time, it settles. So all these symptoms at times can be mild for some people, it might be moderate for some, and for some people, it might be really, really bad. So depending on your personality, depending on what is happening with you, please seek appropriate attention. So the duration varies, the symptoms varies between different people. So, but symptoms typically might last up to 5 to 7 years, but some women can even still have the symptom to continue into the 10 to 15 years. Perimenopause can last for several years. You see some people, they will miss their period for 8 months, and the next day they're like, thinking they've reached menopause, the 9th month they'll see it bleeding again, and they're coming to the hospital to complain because they felt they had reached menopause. So, and also it can also last as much as menopause itself can last, for up more than 13 years. So the symptoms that gives people a really, really bad situation are these vasomotor symptoms, and it can be persistent. Persistent vasomotor symptoms may be associated with maybe your ethnicity. If you get into menopause at early age, if you're smoking, if you have gained weight, and maybe lower educational level. That might just be saying that you might not be able to understand what's happening. You might not be able to know when and how to seek help, because just some lifestyle, in fact, sleep hygiene, what it simply means is that you have a good room, well, not lit for nights, good night sleep. You have an actual time you go to bed. That itself can make you, get over the sleep deprivation symptoms we have in pregnancy and in menopause. So, but if you are not educated, you might not be able to know that just that can solve that problem. Exercise. Which of the day? They say exercise can solve it. What time do you have to do the exercise? What kind of exercise can help you with these symptoms? If you don't know, you don't know. So that's one thing. That's one of the reasons that you might still be having these persistent vasomotor symptoms, even when you think, I've had menopause for several years. I shouldn't be having these symptoms. So what management have we got? To be honest, very few people back home will go to the hospital because of menopausal symptoms, except they don't know that that's what is happening to them, or is becoming really, really, or rather it has affected their quality of life very badly. So to individually, management is an individualized situation. So you need to sit the patient down. We need to let you know, based on your symptoms, there are things we can do. The main things are options is your lifestyle measures. We can give hormones, and there are non-hormonal medications too that we give. So the patient have to understand what menopause is, understand the management options that we've got, then they'll make an informed decision. And that's why evidence-based information about menopause and the treatment options is provided to help women make informed individualized decision about the management by the doctor, depending on what stage of menopause they have, the symptoms they've got, whether they have, health problems. Then you can offer them based on that. For example, you can't be giving some people hormonal treatments when they've got high cardiovascular problems, family history of, okay, my mother had an heart attack, they have family history of DVT, you now give them hormonal. So no. So it's usually individualized based. So I'm not going to go to details of that because I don't see how you're going to benefit on it. So the thing is just that whatever it is, if if yourself are feeling some of these symptoms we pointed out today, or you know anyone that have such symptoms, let the person seek medical care. The doctor in charge will be able to individualize the management for the patient, and they can both make an informed decision of which line of management. But the first thing first, lifestyle measure, that's easy diagnosis. You do not need anyone to prescribe that in quotes. So, for example, the lifestyle advice and measures that we can use if you have got hot flushes and night sweats, what these are the vasomotor symptoms. You could do regular exercise. If you are overweight, try to do exercise that will make you lose weight. At night, you want to sleep, try to wear light clothes. Reduce the layers of clothes significantly. Reduce the, these are just things to make you sleep well and, not to be sleep deprived. Avoid rooms that are very hot if we can. You sleep in a cool room. You use fan. Reduce stress in the day. You should avoid triggers. Yes, one of the triggers are this smoking. I did say that earlier. Alcohol, caffeine. A lot of us are so dependent on caffeine. And they say spicy food. So these are things that you should, you can watch out. Your meals, exercise. If you are sleep deprived, as I've said, avoid doing your exercise late at night. We said exercise, but they're telling you that if sleep disturbance is your problem, don't do your exercise late at night. Have regular bedtime. As I said, that's sleep hygiene. Regular bedtime, make your room cool, make it not too light. All these things can help you, even without seeing any doctor, to help the menopausal trouble of sleep disturbance. For those of us that have had those of them that are going to be having low moods and anxiety, it makes them to nag. All you want to do is ensure that you have adequate sleep, do your physical activities regularly, do some relaxation exercises. Even when you know yourself that this is what is happening to you, when you see yourself you're nagging to your children or to your colleagues at work, you remember that it's menopause. You'll be consciously, when you do a conscious effort, that would help you too. Then for some people that have got cognitive symptoms, exercise and good sleep hygiene would also solve it. So these are just few things you could do that can help your symptoms. So thank you very much. I hope I have been able to point out some few things about menopause, about give rooms for questions, and I'll try my best to answer it as much as possible.
Wow, that was a comprehensive one. And I've asked if anyone also have questions so they can ask. One of my question is where you talked about potential spontaneous resumption of ovulation or spontaneous pregnancy. I think you said that was part of the symptoms of menopause. So I just want to know, could this be related to all those women that give birth at maybe 55 years of age, and people start wondering how come an old person like that is still giving birth? So if it happens that way, like if you are not on any contraception or what did they used to call it, any contraceptive, and you think you are actually going to menopause very soon, would you advise for one to ensure that you're on contraceptive, because anything can happen at that stage?
Okay, so the question at that time when I was talking about the premature ovarian failure, and I was telling you about the symptoms you see. So it's characterized by menstrual disturbance, which can either be amenorrhea or oligomenorrhea, and potential spontaneous resumption of ovulation, menstruation, and spontaneous pregnancy. So that's that. But the question you've asked now is, we see people in their 50s getting pregnant. Menopause has got a range. So for like my mom, for example, I think she did get to menopause at the age of 55 or thereabouts. So you could imagine if our colleagues at 50 had gotten to menopause, some at 45, then menopause already. She could get pregnant at that 10 years gap.
Yeah.
So if she's not on, and that's the room we have for women who have been looking for children for several years, and they will say at 50 she got pregnant. Yes, the ovaries are still functioning. The ovaries are sensitive to get pregnant. So if she does any form of infertility treatment, she could get pregnant. So if at 45 if you have not reached menopause and you don't want to have a child, the teaching is use a form of contraceptives.
Okay. All right. Thank you, Ma. I saw a question in the chat. It came to me privately. Someone asked that, does very irregular menstrual period mean the person is becoming menopausal?
Actually, no. As I said, there are many things that can make your period become irregular. For example, there's something we call PCOS, polycystic ovarian syndrome.
Yeah.
Symptoms too is irregular menstruation. So, and some people, their menstrual pattern itself is maybe one in alternate months. That's their usual, that's their norm. So, but when you start thinking, when you start using that to be a diagnosis of premature ovarian failure, is since I started my menstruation, I usually see my period every 30 days. I never miss it. Anytime I miss it, I'm pregnant.
Exactly.
That's the deal. Now, you now start skipping it at 40. It's
Mm.
not regular. The quantity that I used to use 5 days, ọjọ́ méjì ni àbí ọjọ́ mẹ́ta ni, is now 2 or 3 days. It might be a pointer. And that's why I said diagnosis of premature ovarian failure is a diagnosis of exclusion. You have to exclude many other causes of cessation of menstruation. So when you do all the tests and you exclude that, then you can start thinking about premature ovarian failure. And that's why even if you come to the clinic with all the symptoms of menopause shining at the eyes of a doctor, at your 40 or before 40, she will not tell you that, no, what you're having is menopausal symptom. What she or he will do first is to run some tests. And what is she thinking is, I need to rule out other causes of this situation. If you use some form of contraception, you will not see your menses. So if you don't see, that doesn't mean that you're entering menopause. The contraception is the one causing the hormonal changes. And that's why the menstruation is like that. I don't know if that answers the questions.
Yeah, I hope so. Okay, so I haven't seen other question, but just the last one for me is where you mentioned how one of the symptoms of menopause, which is reduced libido, dryness, and so obviously menopause affects women's sexual life. So I want to believe maybe this could be one of the reasons why women especially they don't talk about it because it feels like a sacred thing that people don't like to talk about. So let's say someone has come to complain, for example, would there be like a drug or is still going to be like an exercise for people experiencing such?
So, as I did say, you'd see that there are different management options. Lifestyle is just basic that you can do by yourself. Do you understand? The
Yeah.
other options are there for you, for the doctors to exploit for you. We have the hormones. We have some medications that we can prescribe that can really help you with those menopausal symptoms. Some hormonal medications and also some that are not hormonal medications. So even creams for vaginal dryness, we give some estrogen creams because this is like localized, and we know the problem. The problem is the fact that the the vagina is dry. So we can give you an estrogen is depleted. So when we give you some estrogen creams, you apply there, it makes it good. So there are medications they will give you that will take off that, and your sexual life will be back on point, which is very
Okay.
important.
Okay, thank you very much. We appreciate your time. Oh, there's a question again. Is it okay for me to ask?
Please do.
Okay, so someone asks that period that is not flowing well, does it mean it is becoming menopausal?
At what age? Age dependent.
Okay, I want to believe less than 40, but maybe light periods and the person just feels something is not right.
Yes, to be honest, if you've had a regular pattern of how it's been since you started menstruation, if there's a change, for example, I usually menstruate for 7 days and now, or 5 days, and now it's barely 1 or 2 days, I think you should seek health check. It may be something else going on, and it may not be anything.
Exactly.
But some of us will say, I saw a doctor. You shouldn't see just a doctor. This is a gynae problem. See the right person. If they do all the tests and they say, oh, sis, don't worry, you're fine, then you can go to bed to sleep. But without that, no one can tell you that what's happening is not it.
Okay. Okay, thank you so much, Ma. I'm not sure if there's any question, but if there are more than what we have had this evening, you are on the group now. So
Yeah.
if any question is dropped, you'll be able to see, or I can bring that back to you.
Oh, that'll be
So
fun.
yeah, thank you so much, Ma. I want to believe, or let me say, I personally enjoyed this session. I'm not looking forward to menopause yet. Anyway.
There's time
but
for
but
everything. The time will
seriously,
come.
I love it because they said information is very, very powerful. And you mentioned that someone at work, for example, might just be nagging, and you don't even know that it's because of one of the symptoms of menopause that you are experiencing. So it means if one is well informed, that means you pay attention to yourself, to your behavior, and how you relate with other people. So thank you so much for the information, Ma. I believe that you have empowered so many women as regards menopause as a topic. I hope we can have you some other time to talk to
Yeah.
us about other women issues. There are so many women health issues. So this is just one of them. I want to say thank you so much, Ma, on behalf of all the members. We hope to have you some other time. Thank
Thank
you
you.
very much, Ma.
Yeah. Thank you very much for giving me the
Yeah,
opportunity.
then someone also said thank you. We have Dr. Kudirat that have joined us. She said thank you, that is quite informative.
Thank you. Thank
All
you.
right, Ma.
All
Have a
right.
great evening. Thank you,
Thank
everyone that have joined. We hope you
you.
enjoyed this session. Enjoy your evening. Thank you.